Sepsis isn't just a simple infection. It's a full-blown medical emergency. It's this high-stakes race against the clock where the body's own immune system basically goes haywire and starts attacking its own tissues and organs. And inside the chaos of an emergency department, figuring out who has it and treating them fast, well, that's one of the biggest challenges a medical team can face. So let's dive into how they tackle this.
And the scale of this problem, it is just staggering. In the United States alone, sepsis costs the healthcare system an estimated $62 billion every single year. That massive number isn't just about money either. It really speaks to the complexity, the intensity, and just the sheer number of people it takes to fight this absolutely devastating condition.
So, what exactly is sepsis, according to the latest thinking? We're looking at the official Sepsis 3 definition here, and the key phrases you gotta focus on are dysregulated host response and organ dysfunction. This makes it super clear that sepsis isn't the infection itself. No, it's the body's overwhelming, life-threatening reaction to that infection. This specific definition, it's the foundation for everything we're about to talk about.
Okay, to really get a feel for this race against time, we're going to follow a patient's journey. We'll start by digging into the threat itself. Then, we'll walk right through the ER doors with them, see how the doctors investigate, watch the frantic race to treat it, and finally, we'll zoom out and look at the bigger picture, something we're calling the pendulum of care.
All right, first up, the threat. Let's really break down why sepsis is one of the most serious enemies in all of modern medicine.
Yeah, these numbers are pretty grim. Sepsis is a top cause of death in U.S. hospitals, plain and simple. As you can see in the chart, the death rate for patients in the hospital is already high. But look how much it jumps for folks who actually get the infection while they're in the hospital. This isn't some rare thing. It's a huge, deadly public health crisis.
Our whole understanding of sepsis has changed a ton, and this slide really shows you why that's so important. Back in 1991, the definition was super broad, mostly based on general signs of inflammation. The problem with that? So many things can cause inflammation. The 2016 update was a massive shift. It lasers in on actual organ dysfunction. This change helps doctors find the patients who are truly in mortal danger, which makes the diagnosis way more accurate.
Okay, so let's apply all that to our patient. Picture someone showing up at the hospital feeling just awful. The second they walk in, a clock starts ticking. We are now going through the ER doors.
In an ER, which is, let's be honest, organized chaos, you just can't rely on guesswork. Hospitals use these incredibly structured workflows, just like this one, to handle anyone they think might have sepsis. See all those clear steps and decision points? The whole process, from the first moment they see you to when they check on you again, it's all designed to get rid of any confusion and get the patient the right care fast.
And really, the first line of defense? It's the nursing staff. Their workflow is like a rapid-fire sequence of events. They triage the patient, do a quick sepsis screening based on vitals and symptoms, and if something's wrong, they immediately notify a doctor and get the initial tests going. We're talking this all happens within just minutes of arrival.
And check this out, because technology plays a huge part here. This is a real sepsis trackboard from a hospital's computer system. When a patient's screening comes back positive, an alert fires and a big red box pops up next to their name. It's a visual alarm that no one on the team can miss. As treatment starts, it turns yellow, and then it goes green once that first batch of treatments is done. It literally turns this complex process into a simple, real-time dashboard for a life-or-death situation. So simple, but so powerful.
Okay, the alarm's been sounded, and now the focus shifts. We're at the doctor's investigation. This is where the physician has to confirm what the nurses suspect and really figure out what's going on with the patient. So what clues are they looking for? They're searching for signs of hypoperfusion, which is just a fancy medical term for when your body's organs aren't getting enough oxygen-rich blood. This can mean falling blood pressure, a heart that's racing, and high levels of something called lactate in the blood, which is a sign the body's cells are really stressed. Even simple things, like pressing on a fingernail to see how fast the color comes back, can give them vital clues that the body is in trouble.
But here's where things get really cool. The old-school physical exam is getting supercharged with technology. Point-of-care ultrasound, or POCUS, has become an absolutely essential tool. It gives doctors a real-time window inside the patient's body, right there at the bedside. You don't have to waste critical time waiting for a big, formal scan from the radiology department.
And they're not just pointing the ultrasound probe around randomly. Nope, Physicians use structured protocols, like this one called THIRD, to guide their exam. It's basically an acronym that gives them a checklist to quickly look at the major causes of shock. They check the heart, the lungs, the big veins to figure out why the patient is so sick and fast. In a situation where every single minute counts, this is a total game changer.
So, after piecing all these clues together, the doctor makes it official right here in the electronic health record. On this alert event note, you can see the patient's abnormal vitals on the left. Then over on the right, the physician officially clicks the button to confirm the diagnosis. That single click makes it official and triggers the hospital's entire sepsis treatment protocol to kick into gear.
With the diagnosis confirmed, now it is an all-out sprint. We are racing the clock, using a standardized set of treatments that everybody calls the sepsis bundle.
The sepsis bundle really has 4 main parts. First, you give large amounts of IV fluids to get their blood pressure back up and get blood flowing to the organs. Second, powerful, broad-spectrum antibiotics to start fighting the infection right away, even before you know exactly what it is. Third, you've got to find and control the source, like draining an abscess. And finally, for the absolute sickest patients, use drugs called vasopressors to basically squeeze the blood vessels and stop their blood pressure from bottoming out.
But, and this is a huge but, the treatment isn't just about checking off boxes. It is this incredibly delicate balancing act, like walking a clinical tightrope. If you give too little fluid, the organs stay starved of blood. But if you give too much, you can actually flood the lungs and make it impossible for the patient to breathe. Doctors have to constantly recheck and reassess, walking this super fine line.
And that whole balancing act, that clinical tightrope, brings us perfectly to our final section. Let's zoom out from this one patient and look at the bigger debates that are shaping how we treat sepsis today. The pendulum of care.
Okay, get ready for this number from the CDC because it is pretty shocking. Nearly a third, 30% of all antibiotics given in U.S. hospitals are either totally unnecessary or just not the right choice. In the mad dash to treat sepsis, there's a very real danger of overtreating. And this doesn't just hurt the patient in front of you, it fuels a massive global crisis, antibiotic resistance.
This quote from Dr. Jessie Roskay just nails the central problem in sepsis care. She's talking about the pendulum of medicine. For years, that pendulum swung way over to one side, towards aggressive one-size-fits-all protocols because everyone was terrified of missing a case. But now, the medical community is realizing that approach has its own serious downsides.
So the whole debate really comes down to this one central conflict. How do we build systems that guarantee every single person with deadly sepsis gets life-saving care right away without overtreating all the people who don't actually have it, which just fuels antibiotic resistance and causes other problems? That pendulum is now starting to swing back towards a more personalized, more thoughtful approach.
And that leaves us with the ultimate question, right? For doctors, for nurses, for everyone in healthcare. There is no easy answer here, but trying to find that perfect balance between aggressive, life-saving action and careful, intelligent medicine, that is the future of sepsis care. It's the challenge that's going to define how we fight this deadly condition for years to come.